Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing U.S. healthcare system. So today we're going to talk a little bit about gynecomastia, which is a major concern for almost every man that is on TRT. At least at some point in their TRT journey, they're going to have concerns about developing gynecomastia. You read about it on the forums. Providers use it as a justification to prescribe AIs, even prophylactically, because you don't want to get gynecomastia, obviously. And nothing terrifies patients I've seen more than the prospect of growing a set of man boobs. And what I'm hoping to do today is explain to you guys that that's not something that you really have to be concerned about in the vast majority of cases. The development of true gynecomastia, especially new gynecomastia in a man who's never had it before, who then starts TRT, the odds of that happening are vanishingly low. And I can say that I can only recall one legitimate case, and it was in a young, relatively young, quite lean, healthy guy. And after I got a little bit more history, it turned out that he actually suffered from fairly significant gynecomastia as a teenager. He had a really significant flare, which is not all that uncommon when a boy enters puberty. It resolved for the most part, and then when he got back on TRT, he legitimately developed just a very small nodule. I believe it was on the right side. So a lot of times it's unilateral. It can certainly be bilateral, but a lot of times one side will be more prominent than the other. And ultimately, he elected to go to surgery and have that excess redundant tissue removed, and he did very, very well. But that's the only case that I've ever seen of legitimate gynecomastia that was induced by TRT. Now, anabolic steroid use is a totally different ballgame. I've seen a lot of gynecomastia from androgen excess in both amateur and professional bodybuilders. That's a whole different animal, and we're not going to touch on that today. So what is gynecomastia? It might be more useful to actually talk about what it's not. So what gynecomastia is not is the development of some nipple like puffiness, itchiness, some soreness, maybe some pain or aching. These are transient symptoms. This is a transient phenomenon and not that uncommon when a man first starts on TRT. There are going to be some major hormonal fluctuations that man is going to experience. Those things sometimes manifest with those symptoms I just discussed, but they don't result in permanent glandular tissue hyperplasia, okay, which is really what gynecomastia is. So there are some transient sensations, we'll call them, involving the nipple area. These will settle down and go away. They do not require an aromatase inhibitor, although many men will use an aromatase inhibitor to at least get those symptoms to go away. And aromatase inhibitors do work for this, because there is an estrogen component to those symptoms. But as I'm going to share with you guys in this video, estrogen is certainly involved heavily, but it's not the root cause of what's going on. It's actually quite a bit more complex than that. So these transient effects, what I've seen clinically is they are far more common in men who are already obese, men who have a lot of inflammatory visceral body fat. Other than the one guy that I mentioned earlier who was lean, I've never seen a significant worrisome case of the symptoms I just described in men who are lean. And by lean, I mean like 10 to 15% body fat. It's almost always in men with higher levels of body fat. So there's definitely an association there. And quite frankly, what most guys think that is gynecomastia is really what's called pseudogynecomastia or adipomastia, which, just to put it bluntly, is man boobs. You have a dad bod and you have excess fat tissue around the nipple and areola, and it certainly looks like breasts. It looks like actual glandular breast tissue in some cases, but it's not. It's really just fat. And this is a picture here of a young man who is suffering from pseudogynecomastia, and this is a pre-op photo here, and yeah, so you can see, I mean, that looks like it could be gynecomastia, but on physical exam, if an experienced clinician were to examine this young man, they would be able to tell by palpating the area that, okay, this is not glandular tissue. This is just adipose tissue. There's a different texture. There's a different feel to it, and they'll be able to tell that. And in some ways, like, this is actually good news, because if this young man, if he drops his body fat percentage, which is quite high, as you can tell from the photo, this is all going to go away. So glandular tissue from true gynecomastia, even in professional bodybuilders who get down to like 2 or 3% body fat, you will still see that knot of glandular tissue there, no matter how lean they get. But if you have pseudogynecomastia and you get your body fat down, it basically just goes away. Now, sometimes there's overlap. I mean, men that have legitimate gynecomastia, a lot of them, like I said, they do tend to be overweight to begin with, so they can have a little bit of both. But they can certainly make their cosmetic appearance look a ton better if they just drop body fat. And that can make a huge difference. And it can actually make enough of a difference where maybe they don't need to have surgery. They don't feel, they're not as embarrassed when they take their shirt off if they just lose the body fat. Okay, so that's pseudogynecomastia. So as I alluded to, true gynecomastia is actual hypertrophy of glandular breast tissue. And the way that you can tell on physical exam is, you can examine the area, you can kind of pinch it, and you'll feel this disc or disc-shaped area of firm tissue right under the nipple. And it's mobile. It can be a little bit tender, and then surrounding it, you'll feel this like fibrous, fibrous connective tissue, sort of like with women that have fibrocystic breast disease. I mean, there's a certain amount of fibrous tissue that develops in men as well. It's kind of a lattice work for where the ductal tissue kind of is supported, and you can feel that as well on physical exam. Now, if that area is irregular, if it's not mobile, if it extends in an irregular shape, like outside of the nipple area, if it's associated with perhaps a lymph node enlargement in the axilla, so those are red flags. If there's a bloody discharge, if there's change in the skin tone or texture, so it looks like kind of an orange peel, okay, that's highly concerning. That actually could be a sign of breast cancer. And believe it or not, men can get breast cancer. Thankfully, it's very rare, but there are many cases of men out there who've died from breast cancer, and the mortality rate's quite high because a lot of times they present late for care. So male breast cancer is a thing. So if you develop a breast mass, whether you're on TRT or not, you get into an experienced clinician and just get that examined. There is a proper workup for this. It may just be simple gynecomastia, but it might not be. There's a lot of other things in that differential, which I don't really have time to go into, but just make sure you've got an experienced provider, somebody who actually knows what a breast cancer feels like and knows how to work it up, because those things are out there and you don't want to miss them. So most of the stuff we're going to talk about today comes from these two papers. So the first one is from the journal Andrology. It's one of my favorite journals. This is from 2019, the EAA Clinical Practice Guidelines, Gynecomastia Evaluation and Management. It's a very comprehensive paper, kind of A to Z on how to work up a patient with gynecomastia. It's pretty good. And then this one is really good too, from the Endocrine Society. It's the Journal of Clinical Endocrinology and Metabolism. It's a little bit older, 2011, but also really good. Approach to the Patient with Gynecomastia. So two really good papers if you want to get into the nuts and bolts of how to do a proper evaluation of somebody who presents with gynecomastia. Okay, so where does this fear of gynecomastia come from? A lot of it, I think, carries over from the bodybuilding world and has spilled now into the TRT world. And this notion that, obviously bodybuilders, throughout the years, even in the 70s, this is Franco Colombo, Arnold's old training partner. And you can see here on his right chest, I mean, he's got this knot of glandular tissue there. And despite the fact that he's absolutely shredded, probably has 4% body fat here, if not leaner than that, and he still has that tissue. And that's what I was alluding to before. If it's just pseudogynecomastia, it's going to completely vanish if you get this lean. But true glandular tissue, it persists, and you can see that there. And this was not an uncommon thing back in the 70s, and it actually still is today. You'll still see professional bodybuilders that will have a little bit of gynecomastia, even when they're in contest shape. Many of them ultimately have to get it surgically removed to further their career, but some of them seem to still place pretty high, even though they still have it. But even back in the 70s, I mean, there's these guys, they were using tamoxifen back then. They didn't have anastrozole or any of the AI medications, so they used tamoxifen, which is a SERM, to prevent the development of gynecomastia, and that's still an option today, and we'll talk just briefly about some of that towards the end. But that's ultimately where this concern comes from, and we just have to remember that testosterone replacement therapy is replacement of a naturally occurring bioidentical hormone back up to therapeutic healthy levels. It's not the same thing as what these bodybuilders are doing, which is not just taking testosterone, of course, but taking it in massive quantities. And then they're also throwing in both oral and injectable synthetic androgens, many of which aromatize heavily as well. And not only that, but they're using growth hormone. And that's one of the things we'll talk about here, is that the overly simplistic approach to gynecomastia is just focusing on estrogen. But the fact is that there are multiple hormonal pathways that are involved in the development of this kind of tissue, and IGF-1, growth hormone, thyroid, prolactin, all of those things are involved, and that's why this is actually kind of a complex condition. And the knee-jerk response to just throw an AI into the mix to try to treat this, I think, is not the right approach for most men. It's certainly not, in my opinion, it's not a great long-term solution for solving this issue. So how common is this? Well, it's extremely common, especially if you're a teenage boy. So somewhere around 60% of teenage boys, probably is higher than that, will develop transient gynecomastia at some point as they go through puberty. And it's completely normal. It doesn't mean there's anything wrong with them. Again, a lot of times it's unilateral. It can also be bilateral. This is a normal transient thing and generally goes away by late teens and early 20s. But in some cases it does persist. So, but this is not anything abnormal. I remember having a little bit of this when I was like 13 or 14 years old, which is typically when it shows up, and it's, it completely vanished as I got older. So again, very, very common. It's extremely common in middle-aged men and older men, and there's a lot of reasons for that. But up to 60 to 70% of men will, especially up to 60 to 70% of older men will have some degree of gynecomastia. So it's extremely prevalent. It's getting more prevalent, and there's a lot of different reasons for that we're not going to get into in this talk. But it is on the rise, and there's some good epidemiological studies showing that it's becoming more common, and it probably has a lot to do with obesity, and in my opinion, probably has a lot to do with endocrine disrupting compounds, which I'm not going to have time to get into here, but in my opinion, likely play a major role in the development of gynecomastia in the modern day. So in addition to the things we're going to talk about here today. So it's important to, remember that, breast tissue has receptors for androgens. It has receptors for estradiol. It has receptors for progesterone and prolactin. So it responds to all of these hormones. It also obviously responds to IGF-1. So it's this cocktail of hormones that in some men is the thing that precipitates gynecomastia. And what's interesting is that many men with the same cocktail of hormones obviously don't develop gynecomastia. So what's going on here? Certainly, an excess amount of estradiol certainly can precipitate gynecomastia. There's no question about that. But more commonly, it's associated with low levels of testosterone. So there actually may be normal estradiol levels, but these are hypogonadal men. So it's thought that this is actually more related to the estrogen to testosterone ratio. When that ratio becomes skewed, even though perhaps the estradiol level may still be technically within the normal levels or within normal limits, that is a risk factor for the development of gynecomastia. But as we're going to talk about here, there's a lot more to this, and genetics play a major role in this because there are plenty of men running around with skewed estrogen to testosterone ratios that do not develop gynecomastia. So why do some men develop this and others don't? Well, I'm going to show you some papers that explain that. Once you see that and you realize that, if you're one of these unfortunate and unlucky individuals that has developed gynecomastia, I think you'll realize that surgery is the way to go to treat this. Okay, this is a pie chart from one of the papers I showed you earlier, looking at all the different causes for gynecomastia, and this is from a large meta-analysis. So what I want to point out is just a few things. So there are some very rare but potentially very serious causes for gynecomastia, and this gets back to what I talked about earlier, is that if you develop this condition or it recurs, you please get seen by a competent provider who knows how to do a proper exam and knows how to work this up. Okay, testicular cancers, 1%. This is actually not an uncommon presentation for certain types of testicular cancer, is to present with gynecomastia, and a man can have gynecomastia as the first presenting sign without necessarily having a palpable testicular mass. The mass itself might be too small to notice, or they're just sort of oblivious to the presence of this small mass. And so, a proper testicular exam, and in some cases a testicular ultrasound, might be part of the workup for this. We talked about the hormones, and we'll talk a little bit more about these: thyroid, prolactin, Cushing's with cortisol. There's some genetic conditions, Kennedy syndrome, which is related to CAG repeats in the androgen receptor. There's a whole bunch of other androgen receptor polymorphisms that might be playing a role in this as well. Now, Klinefelter's 1.2%. So Klinefelter syndrome, if you recall, is a man who has an extra X chromosome. So instead of XY, they're XXY. And it's very common for them to have gynecomastia. Again, likely related to a couple of different things. One being a skewed estrogen to testosterone ratio, but also perhaps a prevalence of estradiol and progesterone receptors in that ductal tissue, which should not be there, or they're there in excess. Testosterone deficiency, okay, big chunk of the pie here, this green and light green. Primary and secondary testosterone deficiency, that shouldn't surprise any of you. Medications is a big one. We're not going to have time to touch too much on these, but a lot of very commonly used medications, okay, including antacids like proton pump inhibitors, okay, those are used very commonly. I use them sometimes. They can cause gynecomastia in certain susceptible individuals. So that's a big chunk of the pie. But the biggest chunk of the pie is this unexplained. Okay, these are men who have developed gynecomastia, and they've had a full medical workup. Their hormones are normal. Nobody can find the reason. Okay, and this is where these genes that we're going to talk about comes into play. So the majority of these men, likely this 57%, where they can't find any other cause for this, likely have some sort of a genetic polymorphism, or one or more genetic polymorphisms that has predisposed them to development of gynecomastia. And again, you can't fix your genes, so that's why surgery is probably going to be the best long-term option for these men. Okay, now one of the things that is not uncommon is that a man who has pre-existing gynecomastia gets on testosterone, and their gynecomastia actually gets better. Okay, you would think it would get worse because typically estradiol levels will increase due to aromatization, but the fact is that androgens, so DHT and testosterone, are directly inhibitory to the growth of this ductal breast tissue, and so this is actually one approach to address gynecomastia, is to raise testosterone and DHT levels. So this is a paper here that goes into the nitty-gritty of the mechanism behind all of this. We don't have to go all the way into this, but I just want to make you aware of this because it's actually pretty important. So this is Androgens and Mammary Growth and Neoplasia from the journal Fertility and Sterility, dated 2002. So they go into a number of different studies in here where they basically lay out the case for stimulation of the androgen receptor as a mechanism to inhibit breast tissue growth. And they actually talk about a number of breast cancer studies where activating the androgen receptor with androgens in addition to standard therapy for breast cancer has actually shown some very positive outcomes. And we're not going to go into that because that's in the female realm, but it's important to recognize, we understand obviously estradiol is stimulatory to the development of this ductal breast tissue, but stimulating the androgen receptor directly blocks that and actually inhibits it. And that explains why, again, many men who have low testosterone, they have gynecomastia, and they start on testosterone therapy, their gynecomastia actually gets better because that androgen receptor is going to work for them. Okay, and this is another study that talks about this. A paper called Testosterone Inhibits Estrogen-Induced Mammary Epithelial Proliferation, okay, as I just said, and suppresses estrogen receptor expression. So that's the other interesting part of this. So not only blocks the growth of the tissue, but it actually suppresses the genetic expression of the estrogen receptor. You will have less estrogen receptors when you have a healthy amount of androgen in your system. Okay, and this is a paper here where they actually looked at rhesus monkeys in here. That's the animal model that they used. So what they found is that the estrogen receptors, so they looked at estrogen receptor alpha, there's alpha and beta, and they gave these monkeys E2 estradiol. And so what happened is that E2 alpha receptor was upregulated and expression increased by 50%. Interestingly enough, when they gave the same amount of E2, but then they also gave them testosterone, that effect was completely canceled out. And it actually, the amount of hyperplasia of the breast tissue that was stimulated by the estradiol was actually reduced by 40%. So that supports our contention that really it's the estrogen to testosterone ratio that really makes a difference when it comes down to whether or not you're going to develop gynecomastia, in addition to the genes that we're going to talk about. Okay, so this gets back to explaining why many men run around with quote high estrogen serum levels, which I'm not going to get too far into why serum estrogen levels are not particularly reliable. I mean, estradiol along with DHT, as many of you know, that's an intricate hormone. So what you're measuring in the serum does not necessarily reflect what's going on in the cell. But having said that, that's why you will see men on testosterone therapy with, estradiol levels 80, 100, 120. Yet they have a very robust and high serum total testosterone levels, and those men do not develop gynecomastia. They develop no nipple symptoms whatsoever. And this paper, supports that. The reason for that is that testosterone is suppressing the effects of the estradiol when it comes to the breast tissue. So it's nice to see this in a paper because it explains what we see in clinical practice, all the time. So what is the best estrogen to testosterone ratio? Nobody really knows. Those assays, like I said, are not typically reliable. There's day-to-day variations in those numbers. So nobody really knows. But there's definitely a connection. And this is a paper here that shows that pretty clearly. It's the title of the paper here is Sex Hormone Profile in Pubertal Boys with Gynecomastia and Pseudogynecomastia. This is from the Journal of Endocrinology and Metabolism, relatively recent, April of 2020. This is an interesting study. So they took a fairly large group of young boys, young men. There was a group that had documented gynecomastia. There was a group that had documented pseudogynecomastia. Okay, so these were fat kids. And then there was a healthy control group. And so they just examined these kids, they took a bunch of biometric readings, and they drew a whole bunch of labs on them. And they were looking for trends. And so just to go through this first chart here, this is what they found. So we see here group 1, the gynecomastia group, average age 13.8 years. The pseudogynecomastia group 13.9, and then 13.7 for the healthy control. So these kids were all roughly the same size. So look at the obesity rate. In the gynecomastia group, 42% were obese. So what's interesting is the remainder were not obese. So the majority were not obese. Pseudogynecomastia, shocker, right? 86% obesity rate, and 0% were obese in the healthy controls, which you would expect. You wouldn't be a healthy control if you were obese, right? But look at the estradiol levels here. I just highlighted like the E2 levels, and they're in picomoles per liter. So you can do the math if you want to. But the point is, look at these numbers. So the gynecomastia group, the E2 was measured at 39. The pseudogynecomastia group was 31, but the healthy controls, it was 41. So the healthy controls who were lean had the highest serum estradiol levels, yet they didn't have gynecomastia. And in fact, all three groups had solidly normal. You can see the reference range there, solidly normal E2 levels. So why did these kids in group 1 develop gynecomastia where the other two did not? Well, we'll talk about that a little bit. Looking at the E2 to T ratio, that's where you get your answer. So the E2 to T ratio in the gynecomastia group is elevated at 22. In the pseudogynecomastia group, it's 12, and in the healthy controls, it was 18. And again, they look down at their total testosterone levels here in nanomoles per liter, and it should not be surprising that the gynecomastia group had the lowest serum testosterone levels in terms of total, 1.8 versus 4.3 versus 3.1, and that's what skewed the ratio. So despite them having like relatively similar estradiol levels, it was this low testosterone level that skewed the ratio, and that seemed to be what, at least that's what the authors used as the primary reason for why these kids developed gynecomastia. You can see it here in this chart. Here, this is the estradiol to testosterone ratio in boys with gynecomastia, pseudogynecomastia, and healthy controls. And you can, the bar graphs here show that quite nicely. Okay. Now, they also looked at their IGF-1 levels because many studies show that it's really, there's more to this, especially in young men going through puberty and probably in adults too. But IGF-1 is a major driver of this. So it's likely that there's some synergy there between a skewed estrogen to testosterone ratio and IGF-1 elevations. Now, it's interesting, in this particular study, there really wasn't a major difference in the gynecomastia versus pseudogynecomastia group. You can see the IGF-1 levels here, roughly the same, 333 versus 339. But there are multiple other studies out there showing that there is a difference. So again, maybe an IGF-1 elevation is not required in all cases, but there definitely seems to be a trend there. Again, I pulled multiple studies that I don't have time to go into here that did show that elevated IGF-1 levels certainly are at least associated with the development of gynecomastia. Maybe not in and of themselves are enough to cause it, but they're definitely associated. And interestingly enough, too, they looked at prolactin. No major difference in prolactin levels here between these groups either. So interesting study. So this one supports that estrogen to testosterone ratio is the primary driver in these young adolescent boys. And again, that's thought to be one of the major players in adults as well. Okay, I mentioned that this is complex and that there are a lot of other hormones involved. We don't have time to go into all of them, but I do want to mention some of the major ones just for the sake of completeness. And I mention these because these are all things that will need to be checked. Okay, when you go in to get a proper medical evaluation for gynecomastia, these are all things that should be checked. Okay. I think most of you are familiar with the fact that prolactin can be involved in the development of this condition, and that's absolutely true. We do know that prolactin receptors are present in male breast tissue, and it's thought that there's probably two ways that prolactin leads to gynecomastia, or certainly can promote it. One obviously is hyperprolactinemia can cause hypogonadism. If it's high enough, it suppresses LH and FSH. So that's going to skew your ratio. But what's interesting is that elevated prolactin levels actually stimulate or activate the progesterone receptor. Okay, and then the progesterone receptor, when it is active, one of the byproducts of activating the progesterone receptor is that you downregulate the androgen receptor, which can further potentially skew that estradiol to testosterone ratio, at least within the cell itself. Okay, so prolactin can lower LH and FSH if it's high enough, but it also stimulates the progesterone receptor, which downregulates the androgen receptor. So there's two different plausible mechanisms there if we look at this a little bit more closely. So the other one is thyroid. Obviously, thyroid should be checked for most, with most conditions. But issues with your thyroid, whether it's too high or too low, can certainly contribute to this condition. So if you're hyperthyroid, then that sometimes is associated with E2 elevations, so estradiol elevations. It raises SHBG, which obviously is going to bind testosterone, potentially lowering your free testosterone, again, potentially skewing that ratio a little bit. Conversely, hypothyroidism, so that's just associated with hypogonadism. You get a lot of times less testosterone production, and then you can actually have prolactin elevation as well. That's one of the things that you have to check in a man that has an elevated prolactin level, is check a full thyroid panel, because low thyroid can obviously raise prolactin and cause the issues that we just talked about. Now, this is one that I think many guys are unaware of, including in many physicians as well. But leptin is thought to be a major player in the development of gynecomastia, and it potentiates the effects of other hormones related to gynecomastia. So this is a paper here that talks about that. The Journal of Biological Chemistry, dated 2020, leptin enhances via AP1 expression of aromatase in the MCF7 cell line. That's a breast cancer cell line. So, but the key words here is enhances expression of aromatase. So leptin, for you guys that don't know, leptin is it's an extremely important adipokine. So it is a hormone secreted by fat cells, including fat cells within the breast, and it's crucial for satiety. It's crucial for energy metabolism. It has like a wide-ranging effects both in the peripheral tissues and in the brain. Way too complex to go into in this short talk, but it is it's crucially important. And if you look at body fat percentage, as a person becomes more obese, you can plot out their leptin levels, and their leptin levels, as shown by this graph here, as they get bigger and bigger, the leptin just goes up and up and up. And that's because they develop leptin resistance. And so the body compensates by producing more leptin to try somehow to get that signal across. And so when you start having these very high leptin levels, now you're in the area where you can, potentially potentiate the development of gynecomastia. Okay. So what does leptin do? So leptin enhances local tissue estrogen production by increasing aromatase expression. Okay, and that's what this whole paper is about. And they prove that in a line of breast cancer cells, but this is something that happens in normal breast tissue as well. So high leptin levels upregulates aromatase. So very simple. More aromatase, you're going to get more estradiol. So again, it's going to skew that ratio a little bit. Now, here's one other interesting possibility, an interesting possible contributor to this condition that I think most people are unaware of, and is actually quite fascinating. And that is that the development of gynecomastia could be related to an infection with a certain strain of adenovirus. Okay, maybe it's not the only cause, but infection with this particular strain of adenovirus, which is adenovirus 36, which is known to prefer fat cells. It's known to cause chronic low-grade inflammation and fat cell hyperplasia in individuals who are infected by this virus. It may play a role, which is kind of interesting, and this is what this paper here talks about. So this is a 2020 article, Annals of Medical Research, Association of Adenovirus 36 and Gynecomastia Development, a case control study. It's a very interesting hypothesis, and I think that they make a case that this actually might be a real thing. So just to summarize, again, adenovirus 36, it has a very special affinity for fat cells. It is associated with the development of obesity. People who are chronically infected with this virus, there seems to be an association between higher levels of body fat. So this is a relatively small study, but they looked at 33 adult men. Average age was 26.4 years. And these men actually were relatively lean. So they all had BMIs of 25 or less. So they were not obese in this case, but they all had gynecomastia, and they presented for surgery to a clinic, I think somewhere in Turkey, to have their glandular tissue excised. And so they took out the tissue and then they tested it for antibodies to this adenovirus 36. They also measured serum levels of a number of different hormones like leptin and inflammatory markers like IL-6 and a number of other things. And then they compared it to a group of like 15 controls with similar demographics who were presenting with like some other condition not related to gynecomastia that were presenting to the same clinic. So what they found was that the men who presented with gynecomastia, 24.2% of them tested positive. So roughly a quarter of these men tested positive for this particular virus, and 0% of the control group. And then the men that tested positive for the virus also had higher leptin levels. So it's an interesting hypothesis. It's certainly not definitive, but it shows that there may be something to that. And maybe in addition to having all of those other issues that we've talked about, you throw in an adenovirus infection in there, and maybe that's the thing that tips a particular man over the edge and causes them to develop gyno when, or perhaps ordinarily they wouldn't. I would love to see some more studies on this. There are other viruses out there that are associated, probably indirectly with the development of gynecomastia. You'll see it sometimes with HIV, hepatitis C. There's a few others that escape me right now, but this is the first one that might actually like directly cause it rather than through an indirect mechanism like some of these other viruses. So anyway, it's interesting. It's food for thought, and it's something I'd like to see some more research on. It's certainly kind of fascinating to think about. Again, this still does not explain why some men develop gynecomastia and other men don't, despite having very similar hormonal profiles. And as I alluded to before, this really comes down to genetics. And we're scratching the surface in this area, but we have definitely identified a number of genes actually they're almost certainly related to gynecomastia. And I think as time goes on, we're going to discover more, and we're going to find that this is fundamentally a genetic predisposition that is expressed when the hormones become skewed, essentially. Okay, so this is a paper here that talks about a few of these genetic polymorphisms that are related to gynecomastia. This is from the journal Gene. It's genetic variants of estrogen beta and leptin receptors may cause gynecomastia in adolescents. I think they mean adolescents. And this is from 2014. So summarizing this paper, they just go through a whole bunch of different studies and list a number of different polymorphisms that seem to be very strongly associated with gynecomastia. One of the major ones, and the one that seems to be one of the more common ones, is this GPR30 gene polymorphism. So GPR30 is a receptor that binds estradiol. It's not the classic estradiol receptor. So GPR stands for G protein coupled receptor number 30, and it binds with very high affinity to estradiol. It doesn't bind any other estrogen, so no estrone. It doesn't bind to progesterone, cortisol. It's just for estradiol, and it sits up in the rather than floating like in the cytosol, it's actually in the membrane, and it's responsible for some of the what they call the non-genomic effects of estradiol, which tend to happen very quickly. So anything that's like G protein related, that tends to be a fairly quick response. as opposed to a receptor that binds to the nucleus, and there's DNA transcription and then protein synthesis. That's something that takes many hours in most cases. But these G protein receptors, they work fairly quickly, and that's what this is. And there's a host of polymorphisms in this GPR30 gene, which have been strongly associated with gynecomastia and maybe major players. They also talk about a host of other ones that are related to the estrogen receptor alpha, so ones that actually bind to the nucleus. So polymorphisms in that particular receptor, as well as the estrogen receptor beta. So the two different nucleic estrogen receptors. There are a number of polymorphisms there, which cause it to have a higher affinity for estradiol in some cases, to bind it more tightly, that are related to gynecomastia. And then in addition to having high leptin levels can precipitate gynecomastia, having a number of these genetic polymorphisms in the actual leptin receptor itself, which cause it to be more active, can again precipitate gynecomastia. So it's fascinating. There's a lot of these genes that are just being discovered now that seem to be like really, estrogen gets the blame, but really it's these genes that are the root cause in many of these cases. Now, this is another interesting study from the Breast Journal 2019, which talks about these estrogen, and in this case also progesterone receptors, as being probably the culprit for gynecomastia in these cases that are otherwise unexplained or idiopathic. And so the title of this paper is The Role of Expression of Estrogen and Progesterone Receptors in Idiopathic Gynecomastia Etiology. So super interesting. So what they did here is they took a group of men, there's 46 of them, with idiopathic gynecomastia. Again, that was that piece of the pie that was unexplained. So there were no obvious hormonal deviations. There was nothing else that they could find. There were no medications. They weren't using anabolic steroids, etc. No reason was found for these men to have gynecomastia. So they underwent surgery. Average age was 26.6 years. And then they examined the tissue. So they took the glandular tissue out. And through a variety of different complicated immunoassays, basically tested for the presence or the absence of both the estrogen receptor alpha and beta and the progesterone receptor, which normally should be in very low or almost undetectable quantities in this male tissue. So they compared it to tissue that was removed from teenagers who developed gynecomastia, and they had very low to, in some cases, undetectable estrogen receptor and progesterones using the immunoassays that they used in this particular test. It's not that they weren't there; it's just that they're in a very low concentration in these teenagers with gynecomastia. And again, gynecomastia in young teenage boys is considered to be normal. There's nothing thought that there's really nothing genetically wrong, they think, with young men that develop that condition. So they served as the normal controls. But what was really interesting about this is these 46 men with idiopathic gynecomastia, when they looked at their tissue under the microscope, when it was exposed to these immunoassays, 100% of them had very high levels of both the estrogen and the progesterone receptor. So 100% of them did, which was kind of an unexpected finding. So they said the average estrogen receptor expression among sampled cells, it was between 61 to 100% of the samples tested positive. And then for the progesterone receptor, it varied between 31 to 90%. So they concluded that that there's a good chance that these idiopathic gyno cases that are running around out there that we cannot find a reason for, probably for genetic reasons, have very high concentrations of both the estrogen and in some cases the progesterone receptor, and that makes these guys vulnerable to the development of gynecomastia. So super interesting study. I've yet to find one that has, I don't think that they've replicated this yet, but I certainly would like to see that, to see if this is something that holds up. But it would explain why, again, under almost identical hormonal conditions, why one man develops gynecomastia and another does not. Okay, let's touch on non-surgical treatment real quick. This could be a whole nother talk in and of itself. So the most common thing that is done if a man even feels like he might be even close to developing gynecomastia is he gets thrown on usually anastrozole, and that's unfortunate. It certainly does work, but it doesn't really take care of the underlying issue, which in many cases is a genetic problem. But this is a list of other medications that gets used. Now, tamoxifan's been used forever to treat this condition. It's actually quite effective. It's got a pretty good safety profile. I suppose if you had to use something to treat gynecomastia, tamoxifen would probably be a reasonable choice. If you felt like you had to block the estrogen receptor. Now, raloxifene, it gets a fair amount of clinical use from what I've seen. I don't personally use it, but I have colleagues that do that feel like it works well. But there's not a ton of support in the literature. It says here there's only 2 studies that they were able to find in this particular paper, and there was a reasonable failure rate. So a number of patients still had to go on to surgery eventually. So, but it is an option. Clomiphene gets used as well. Now, what's interesting is what works extremely well is giving these guys DHT, which again is going to skew that ratio in a more favorable direction, right? So the added advantage of DHT is that it doesn't aromatize to estradiol. So if a man is on testosterone, you could potentially add some in these cases they generally use topical DHT. I personally haven't done that, but that's certainly an option. You could certainly add some DHT into the mix. It's well tolerated. It is it's highly effective, and there's a number of different studies out there showing that it can be effective. So something to consider. But again, if the underlying cause for the gynecomastia is a genetic reason, which again I have a feeling the vast majority of these are genetic. It's one or more of these polymorphisms that are out there. These medications don't address that. So you've got to make a decision. If you're unfortunate enough to have developed gynecomastia at some point in your life, do you want to take one or more of these medications either continuously or intermittently throughout your life, for potentially up to the next 40 or 50 years, depending on, when you start testosterone and when you develop this condition, or do you want to just bite the bullet and get the definitive treatment, have the tissue removed by a competent surgeon, and then hopefully it will not recur if they do a good job with the surgery? I think I would choose the surgery, each and every time, because, all of these medications have side effects, and, they don't resolve the underlying issue. And again, surgery doesn't change your genetics, but it removes the offending tissue, and it's not going to go back. In these cases, all of these medications will reduce the size of the tissue, but it doesn't go away. It just shrivels up, and it becomes less prominent. But it's certainly, if the conditions are right, can come right back again, and then you're back on the medication again. So, again, my preference and when I counsel patients on this is I recommend surgery ultimately to get it fixed. Now, if they want to try one of these medications just for a short period of time to kind of get things under control, give them some time to make a decision, okay, fine. You approach that on a case-by-case basis. But really, surgery is the way to go. It's just where we're at with this. Until somebody comes up with something more novel, surgery is going to be the definitive treatment for this condition. Okay, which again, in the setting of a normally dosed TRT protocol, is going to be vanishingly rare. If you don't have gynecomastia and you're considering starting testosterone replacement therapy, you do not need to start on an aromatase inhibitor to prophylax this. Okay, if you get a little bit of itchy nipples, puffy nipples, a little bit of nipple discomfort, that's a transient phenomenon. Now, yeah, an AI will hasten the resolution of that, but it's going to go away on its own in the vast majority of cases. You're not going to wake up the next morning and you're not going to need a sports bra. Okay, you're going to be okay. So that's a conversation I have to have quite often. It's just not something that you really need to worry about. Now, if you have pre-existing gynecomastia, maybe you developed it in puberty and it never went away. Maybe you abused anabolic steroids for a long period of time and you have gynecomastia from that. Well, again, you probably have one or more of these genetic polymorphisms in the background. And again, surgery is going to be the way to go. Surgery is going to be the way to go. So that's all I have for you guys today. I don't want to harp on the surgery thing anymore, but I hope you found this useful. I hope you found it informative. Gynecomastia it's a complex condition. It's dumbed down a little bit these days. I mean, we just think about estrogen. Okay, well, if estrogen causes it, then we have to block the estrogen. But there's a whole lot more to it. There's a bunch of other hormones that are involved, as we talked about. And first and foremost, and most importantly, there are a host of genetic polymorphisms out there, which many of us have, that are going to predispose a man to developing this condition. And unfortunately, there's not much you can do about it. If you have the genes, you have the genes. You can't change your parents. Okay. So again, I would encourage you to talk to a qualified surgeon. If you have gynecomastia, if God forbid you develop it, talk to a surgeon, get the definitive treatment, and then just move on. And that way you don't have to mess around with SERMs and AIs and androgens and all these other medications that are used. You just don't have to mess around with it. Just get the treatment done and move on with your life. So that's all I have for you guys today. If you have experience with this directly, either with medication or with surgery, or if you have anything else you'd love to share about it, I always love to hear from you guys. I will catch you next time. Bye-bye.
All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.